Okay, good afternoon, Fernanda. My name's Lorelei Jones, and welcome, Croeso, to the Academy for Health Equity seminar series. It is my great pleasure to introduce today and to welcome my colleague, Jane Noyes, who is Professor of Health and Social Services Research and Child Health. And Jane is an international leader in nursing research and is one of the most highly cited academics worldwide. So I'm very excited to have you here today, and thank you very much for coming.
Great, thanks Lorelei, and I'm immediately going to introduce you to two really key people in my team. We've got Dr. Bianchim here. May is actually based in Swansea, and we sort of work virtually with May, and also Ellie Crane, who's based in Sheffield, and we work virtually with Ellie. Today we're going to present our research findings about a project which was about value-based healthcare. Now, for those of you who may or may not know, that Welsh Government has really signed up to value-based healthcare and put an awful lot of money into it. So I thought I'd start off with a little bit of context about value-based healthcare. So you'll probably all be aware in the National Health Service that in the past we've really relied on metrics such as processes, so number of patients treated, time to receive treatment, waiting times, that sort of thing. But that says nothing about the value or the quality of care, or what patients might value or what they want out of their care. So the value-based healthcare approach in Wales involves introducing what they call patient-reported outcome measures to be completed by patients so that they can actually share their questionnaires before they come in for episodes of treatment. So the patient-reported outcome measures are called PROMs for short. They were originally designed for research purposes, so a typical trial would have a patient-reported outcome measure as an outcome measure, as a questionnaire. They are validated instruments, and in a value-based healthcare context, you could have several questionnaires put together for patients to actually answer, and they're delivered by their mobile phone. So both NHS Wales and NHS England have invested an awful lot of money in the implementation of patient-reported outcome measures in a routine care context. We applied as a team to Health and Care Research Wales in a competitive funding round to evaluate the policy and its rollout. And we worked with the leading health board who were leading the way with the rollout of value-based healthcare and the Wales value-based healthcare team. And we looked at 4 tracer conditions: epilepsy, Parkinson's disease, heart failure, and cataract surgery. Now, epilepsy, Parkinson's disease, and heart failure were all nurse-led services, and cataract surgery started the care pathway with the ophthalmologist in the community, and the problems were reviewed by an eye surgeon. And so we were particularly interested around the questions of equity. The value-based healthcare team in Wales were particularly concerned that introducing value-based healthcare, rather than trying to neutralise some of the health inequalities, it might exacerbate it. So we wanted to see what was working for whom and in what context, and were there justified concerns about value-based healthcare and the use of PROMs? Was it actually further widening the inequalities in access to services and patients' engagement with their treatment and the outcomes that they wanted to achieve? So I'm going to hand over to May Bianchim now, who's going to present jointly with Ellie, and then I'm going to come back at the end and ask them a few questions. We've opened up the Q&A, so if you want to post some questions as you go along, we'll come back to a more formal discussion once the presentations are over, but please feel free to put your questions in the Q&A part of Teams, and then I'll come back, review them, and pick them up at the end. So I'm going to hand over to May. So May, over to you to share your screen.
Thank you, Jane. That's a very good introduction. So I'll probably skim through my introduction because you mentioned very key points. So thank you for that. As Jane mentioned, Ellie and I will be sharing the presentation, so you might hear her coming in, and we'll be switching between us. So today we want to tell you a bit about the equity paradox of using PROMs within the within value-based healthcare, as Jane mentioned. So the whole idea of value-based healthcare really is to shift the way we think about care. So basing the care on what is needed for the patients, so patient needs, then leading the care. And that would mean that your resources then are shifted towards those needs, and your patients are more empowered, so more active on their own care, and this should lead to better outcomes. So this is the whole idea, as Jane mentioned. But is this actually happening? So it's great in theory, but we wanted to measure and understand, is this happening? And we know that every context will receive interventions differently. So in the Welsh context, how is this happening? And if you think more closely, what about in the health board context? So just to give you an idea, this was the Naran Health Board that Jane mentioned that we worked in partnership with. And those were the services we looked at. We purposefully selected those services. They're quite different. They span different patients, different age groups. And so heart failure, for example, have a more elderly age group. Epilepsy, you have a mixture of younger people. Cataract surgery is more like an acute surgical intervention. So they're very different. So the idea is to understand how the same program works differently. So which is value-based healthcare. And just to add a bit more context to you, each one of those services received, they implemented the value-based healthcare with a certain level of flexibility. So they could choose how they would implement it with the support of the value-based healthcare team. And we did the realist evaluation in all of those 4 services. And the realist evaluation is great for complex interventions. It looks at a system level and is really good for answering the very complex questions, which are what works for whom, in what context, and why. Ellie, I don't know if you want to come in for the SRY bit.
Yeah, so just to highlight that the SRY, so SRYs are an economic analysis tool to quantify social and economic benefits from the perspective of patients. It can encompass lots of different stakeholders, so patients, the health services, it can also encompass the environment. And within this context, we looked at patients and the NHS as stakeholders, and it was conducted across all the services except cataract surgery, because it had been discontinued at this point when the SRY analysis started.
So how we did that. So this is our data collection. I'm just going to go through very briefly. If you have more questions at the end, we're happy to answer. So this encompassed the realist evaluation side, encompassed all of those data sources you can see on the screen. So we started by doing a scoping review to see what was out there and how PROMs worked in different contexts and different systems. So we included 43 studies that looked at the use of PROMs within different conditions. We also interviewed 105 patients, carers, and healthcare professionals across the 4 services. We also did a documentary analysis. So this included documents that were used to inform how the programs are implemented. So for example, reports, pilots, any initial analysis that was done when the implementation was early days. This work involved a large group of patient public involvement and engagement. So charities, patient groups, workforce, they were involved from the beginning to the end. So through various different stages of the research. And we also use service data. So for example, number of hospitalizations, number of appointments, medications, and we developed questionnaires to understand more closely how patients related to the questionnaires, answering PROMs. So for example, completion rates and all of that. And if you want to come in from the SRI side.
Yes, so the SRY used a slightly less broad scope of data. For evidencing outcomes, we use routinely collected data and questionnaire data, and also PPI involvement and engagement was involved. And also in the developing theory of change models, the scoping review and the realist analysis were very helpful. So less directly use the data from the realist analysis, but it was pretty important throughout.
So when we started a realist evaluation, the first thing we do is build an understanding of how the system, how the program should work in an ideal scenario. So think of this as the blueprint. If you have this blueprint, then once you collected all of those sources of data that I just mentioned, you can test each one of those, the blueprint, to see how things are working in real life. So that's what we did. So our blueprint is a lot longer than this, but because we don't have a lot of time, those are the key messages. The program, the value-based healthcare program using PROMs, should be working at 3 different levels. At the clinician level, this would mean that the clinicians are using PROMs to triage patients, to monitor how severe the symptoms are, and then decide on the next steps and their approach to care based on the PROM scores. So that means that they would use PROM to tailor the care based on needs. At patient level, that means the patients will be completing PROMs to understand more about their health, to self-monitor the health. This would help them understand how their symptoms are, if they're getting worse or getting better. Think of this as like tracking your steps. So you're tracking something constantly, and you can look back and see if things have changed, if you've done more steps or less steps, and really understand your health and well-being. And this would, in theory, help them to self-manage better and earlier. And the third level would be the service level, is where you have data from the whole service. So you have an understanding of the patient's needs across the whole of the service. This will help you to spot areas where potentially there's a higher need there. So you know, or maybe I need to shift more resources to that area to address those higher needs. So this is how we should work in a perfect scenario. When we measured across all of those 4 different services, what we found is that it was only working in a model way, let's say in a perfect way. Not perfect, nothing is perfect, but it was only working heart failure. And this is how it was working heart failure. So the patients would complete PROMs even before they entered the service. So as soon as they were referred, they would receive a PROM, and they would complete the PROM. And this would give the staff a level of severity, an understanding of the severity of those symptoms for that patient. So the patient would start the service in a different pathway, depending on the severity of their symptoms. If they had mild symptoms, they would go into a quicker pathway. They call it the optimization pathway, where this would be a lot more focus on optimizing the medication, helping the patient to deal with those mild symptoms. So the time allocation would be different. So those patients would have a shorter amount of time with the staff. If the PROMs showed the patient had a severe symptom, they would go into the complex pathway, where they would have more time with the staff. They would have access to a multidisciplinary team, and they would, which will be ideal to address the complex symptoms they were presenting. What this did is that instead of the patients receiving an equal amount of time, equal amount of resources, this was split based on need. This was redistributed based on need. So this really helped to reduce the mortality. Patients who had urgent needs received their care quicker and earlier. So this really worked for the health failure pathway. So you can see here how PROMs were used to tailor the pathway based on the patient's needs. And then Ellie, if you
sorry.
It's okay.
So for the SRI analysis of the heart failure service, we found that there was quite a strong social return on investment ratio of £5.55 of social value for every £1 invested. And the ratio itself, though, is not the whole story. And what really matters is why the ratio was giving a good return on investment and where the value was derived from. So the value from the heart failure service is being generated from a mix of patient and service benefits, so social and economic benefits. Patients were noticing a difference in their care, such as things like being better at self-managing their health and receiving access to services more quickly. And the service was also running more effectively. So this is creating both social and economic benefits for the patients and the NHS. And in the heart failure service, a really key part that we found of why they were generating value is that PROMs were not tagged onto existing clinical pathways, but were actually used to shape how the service works. The heart failure service was designed so that PROMs are meaningfully helping staff and patients. And because staff and patients can see how helpful PROMs are, there was enthusiasm and also high utilisation of PROMs, so there were higher completion rates. And so the main learning from this is that, PROMs have to be really carefully implemented, and it needs to be tailored, and also continued iteration and development to sort of implement PROMs in a way that actually continues to improve and work. And the next slide, May.
Perfect.
Sorry, one moment. Got a lag on my side. So the new PROMs implementation and the clinical pathways in heart failure resulted in reduced waiting times from an average of 70 days to just 17 days. And also the nurse caseload decreased from 120 patients to 50, which allowed them to focus on patients with the most active and complex needs. And PROMs are essential in the heart failure service for the development of these tailored pathways and better outcomes. And this came from more effective triage, meaning that patients are referred to or given care most appropriate to their needs more quickly. And when PROMs are being used to effectively refer patients, this also has the potential to reduce reliance on who is most able to understand, articulate, and advocate for their own healthcare needs. However, as May was saying earlier, this only really holds if individuals can access, complete and benefit from PROMs, and only if the service has the capacity and means to respond and utilise the PROMs. Back to you, May.
Thank you. And I think there's a great final sentence there, Ellie, because one example where the service didn't have the resources to treat what was being measured by PROM is epilepsy. So, for example, in epilepsy, we found the way the PROMs were implemented was to look at anxiety and depression. So we know the patients with epilepsy, if they have mental health disorders such as anxiety and depression, it makes it a lot harder to control their epilepsy, and they're quite common together. So the comorbidities, they happen together. So the service saw a real need there. So PROMs were used mainly to measure anxiety and depression in patients with epilepsy. However, the neurology department didn't have any structure to treat mental health disorders. So they were referring to other mental health services. So they're happening 2 different ways. So if the patient completed the PROMs and the PROM score showed that they had mild anxiety and depression, they received a letter or an email telling them to access online CBT. SilverCloud, I don't know if you heard of it, but it's an online resource for patients with general mental health conditions. So it's not specific for epilepsy. And the patients sometimes couldn't access it depending on their resources, if they had access to online digital resources. And others said it was not specific enough for them. So this is the case of mild mental health conditions. If they had complex and severe mental health disorders, they were referred to another team, so a mental health team, a community mental health team. However, this community mental health team had their own triage processes, and it was overcapacity as well. So that meant the patients sometimes were waiting a long time or not even able to access those services. So patients kind of felt like they're back and forth between the services, between neurology and mental health services, without having any resolution. So the problem here is bringing awareness of a need, which is mental health conditions, without being able to provide treatment for that. This was acknowledged by some of the staff members. Consultant acknowledged they had reservations about creating awareness of a problem they didn't have a solution for, and then who becomes the owner of the risk. And also for the patient side, is that feeling of, okay, I had my concerns validated, I have a mental health issue, what do I do now? So the PROMs being used there, but without a resolution for those patients' needs. Another important thing to mention is the completion rates for PROMs in epilepsy wasn't as good as the the completion rates for heart failure. So in heart failure, you had 70%, over 70% of patients completing PROMs. In neurology, you had less than half. So we only know the story for those less than half patients that were completing the PROMs. So you don't have the voices of the whole cohort of patients. So over to Ellie.
So the findings from the realist analysis are really also reflected in the SROI for the epilepsy service. So the SROI ratio was approximately 85 pence of social value for every £1 invested, meaning that the estimated value was proportionally less than the investment for running PROMs. So this doesn't necessarily mean that PROMs had no benefits, but it does show that the anticipated outcomes were not achieved. And it's also important to acknowledge that there are constraints of the analysis, and potentially we didn't measure outcomes. We measured outcomes within a year, so there could have been outcomes that we didn't capture within the scope of this evaluation. But the main intended outcome from PROMs in the epilepsy service was improved mental health outcomes for patients. And as May was saying, although PROMs are successful at identifying mental health needs, and some patients did benefit from this awareness, a significant barrier to achieving more value is that patients had no access to appropriate mental health supports, or not no access, but very limited access. And this was strongly reflected in the SROI analysis, where we found no value was derived from improved mental health outcomes in patients. And so most of patients were referred to an online platform, which wasn't tailored to epilepsy patients. So I guess the key insight here is that PROMs don't automatically generate value simply by being implemented. There needs to be follow-up in place, and the service needs to have the capacity and infrastructure to respond to the needs that PROMs identify. Back to you, May.
What about the other two services then? So in cataract surgery receives thousands of patients every year. So they're dealing with a really high caseload. When PROMs were first implemented, they were done on paper because the IT wasn't quite there yet. So the systems weren't really integrated. So what happened then is the staff had to manually input the PROM scores into the systems. As you can imagine, doing that for thousands of patients is just not really feasible. So they end up discontinuing this. There's a new software being developed, and once this is in place, they intend to go back to using the PROMs, but for now this has stopped. In Parkinson's disease, the PROMs data was collected, but it was not used. And there's many reasons for that. So first of all, Parkinson's presents very differently. So patients are at different levels. And the staff had a lot of problems matching the PROMs to the patients. So, for example, the patients would receive the PROMs, and after 2 weeks, they would go to services. That PROM data is already outdated. A lot already happened to the patients. So they had to do all the evaluations again. There are also a misunderstanding about what the PROMs were for. So staff mentioned to us that they don't feel the PROMs gave them enough information to make referrals. However, PROMs are not really there for that reason. They're not clinical tool. They're a tool to identify needs and help both the clinician and the patient to make goals together, to do shared decision-making, and to help tailor the treatment. So there's this misunderstanding. So perhaps a bit more training was needed there for both the patients and the staff members on how PROMs could help. So there's a question there about all the data being collected and not used. What happens then? And there's also a mismatch between what the patients wanted to achieve and what the service was providing, even before PROMs was implemented. So patients wanted to maintain function. They wanted to be autonomous. They wanted to continue doing their daily life. They wanted access to physio, OT, occupational therapy. So they wanted to access all of those resources. And the service was a bit more focused on medication, helping to adjust medication. So there's this mismatch between what the service was providing, what patients wanted from the beginning. So that just shows that implementing PROMs in a service that is not running smoothly already, it's not going to be a solution. It's not really going to fix it.
So here's the SROI results for the Parkinson's service, and we found a small positive return with £1.29 of value generated for every £1 invested. And this shows that PROMs are associated with some measurable value in this service, but the magnitude of this value is much more limited compared to heart failure, and arguably also within the sort of the range of measurable error. There was also a very small sample size in the questionnaire for this service, and we also weren't able to get any service, routine service data outcomes. So this analysis is probably less reliable in comparison to the other two SROI analyses. However, I think based on what we found from the realist analysis, we probably didn't underestimate the value derived from PROMs in the Parkinson's disease service by any sort of significant amount. And I think from the realist analysis, we can understand that the value wasn't really achieved because Parkinson's wasn't implemented in a customized way, and there weren't the services or the support needed to actually generate value from the PROMs. Back to you, Ellie.
Thank you, Ellie. I think another important point to mention here is the staff member. So patients had direct access to the staff member. They could contact them at any time. So that kind of bypassed, if you like, the PROMs, and they just contact her at any time. So this is another point to consider, but it just highlights how different all those services used and implemented PROMs. As Ellie said, PROMs really didn't change the way the pathways worked for Parkinson's disease or epilepsy, and that really reflects on the SRI findings. So if you think about equity, then who are we leaving behind? This all includes the voices of those who can access PROMs, which was mainly done online. Some of the services tried to get around this by giving patients tablets during the clinics so they could access PROMs, or even getting family members or carers to answer PROMs for the patient. However, this has so many implications for the patients. There's also the language barrier. So the PROMs were English only. So all the non-English speakers then are not able to access PROMs or would need a translator to help them access PROMs. So then you're only including data from that population who are able to have digital literacy, who have access to computers or technology, or who can get someone to help them with the accessing the questionnaires. Another point to think about is the conditions. So each condition will have different impacts on the patient's ability to access or respond to those questionnaires. So for example, for Parkinson's disease, depending on the severity of the case, they might have more tremors, difficult with fine motor skills, so being able to hold a tablet, hold an iPad and answer the questionnaire. For cataract surgery, the patients who completed the questionnaires mentioned that sometimes they went completely blind, so they had to get a family member to help them answer the questionnaires. They couldn't see the point of answering the questionnaires because every time they did the questionnaire, they just felt like it was just saying they're getting worse and worse about the cataract. And the only way this could be resolved is with surgery. So there's nothing they could do themselves to help self-manage. In epilepsy as well, there's a cognitive load already and memory loss. So there's certain obstacles for trying to remember how you completed the previous questionnaire and monitor your symptoms. Another point to remember is the PROMs, the way they're implemented, they are tools designed for research. They're long, they're not always fit the routine care. The questions are not always relevant. It's good to mention here that the only program that changed this, the only service that changed this was heart failure. Heart failure was flexible in terms of how they use the PROMs. They modified the questions within the PROMs to fit the patient's needs. And we can see they worked quite well. This resulted in a shorter questionnaire that really matched with the patient's needs. So patients felt more motivated to complete the questions, which didn't happen in the other conditions.
So I just want to also briefly highlight what the SROI did not capture, because it's really important for interpreting findings and understanding how to interpret these numbers. So first, the analysis focused on patients in the healthcare service and didn't include carers or family members, limiting the scope to the perspective of patients in the NHS in terms of where value is generated. Second, we also limited the analysis to a 1-year timeframe based on the availability of data and what we could sort of meaningfully measure. And this means that long-term impacts of PROMs, such as sustained improvements in outcomes or longer-term service efficiencies, were not captured. And additionally, we're also constrained by what can be measured and captured, and the resources that we have in capturing these outcomes, as SROIs can be quite challenging to conduct in complex health services. Third, we didn't conduct any subgroup analyses, so we can't determine from the study whether PROMs generated different levels of value across different populations or different groups, and what this would mean in terms of interpretation and how we understand PROMs going forward. For example, I think we can understand from our findings there's probably a bias in the questionnaire data that we gathered towards patients who are digitally literate. And I think this group is probably more likely to benefit from PROMs. And then finally, the realist analysis was really essential in interpreting the findings from the SROI. The SROI shows how much value is generated, but without the realist analysis explaining why value differed across the different services, I think the results would have been quite confusing. And I think it shows how valuable it is to have an evaluation like a realist analysis parallel alongside economic analysis such as SROI. Back to you, May.
Thank you, Ellie. And I think that's what you just said, Ellie, is so important, because we need to understand what needs changing, isn't it? What would need to change in order for the programs to succeed? Because there is a real potential there. It's just how things are implemented. So we can learn with heart failure, and it was a real success with PROMs being completed more, so 73% completion rate, and really real value there for heart failure. So what they did differently, it was really co-designing how the PROMs were used and changing based on need. They implemented a dashboard where patients could go to the service and look at their own scores. So they had access to the scores. In the other services, this didn't happen. So patients didn't really have access to their own scores. So they couldn't really see what was changing from every month whenever they were feeling the PROMs. So it's harder for them to monitor their own health if they cannot access their scores. And also heart failure, like we mentioned before, really used PROMs to tailor the pathway. So they basically put patients' needs at the top, and that really informed how the patient would receive care based on patients' needs. And as in comparison to other services, they tried to fit the PROMs in, but that didn't really inform much of what was going on. It was more like, let's try and fit the PROM in with the systems that are already here, instead of using the patient's needs to inform how things were done, really, the care. So another thing to mention is heart failure had a champion, so someone that was really invested in true value-based healthcare, who understood it and who really drove change within the service. So I had a really strong leadership, and that really helped with training the other members of staff about the importance of PROMs, and really being a champion for the use of PROMs. So they were the only ones that changed a systems level, that showed the systems level change by using the PROMs, where they had identified within the whole of their service areas of higher need, and they shifted the resources, sending more nurses to the area, so patients with higher needs would have more capacity there, more care. So that really shows it's not only adding the PROM, it's just using it to inform the service, how the service is running, providing the feedback to patients so they can really take ownership and be empowered about their own care, and use it to redesign how the service is working. So those are the factors for a successful implementation. Ellie, I don't know if you want to add anything else.
Yeah, just a few of the main kind of takeaways from the SROI analysis is that I think it shows that the value of PROMs is really dependent on how PROMs are implemented and used in practice, rather than the PROMs themselves just generating value just by being tagged onto a service. But I think the results show that PROMs really can work and generate value for both patients and the NHS, but this isn't going to be universal. And there's a lot we don't understand about PROM implementation, but the impact could also vary a lot by the service context, how they're implemented, different patient populations and conditions, and the leadership and the enthusiasm that staff have for PROMs. And I think it's probably quite clear that they're not a silver bullet for struggling services. So yeah, I think careful consideration is really needed in selecting PROMs and tailoring appropriately to services, and continuing to monitor and evaluate so that we can improve understanding of what creates successful PROM interventions. And back to you, May.
Thank you, Ellie. So just a last bit of message there. If you were to simplify everything into one message, so the importance of co-designing and really involving patients into this process. So if patients were involved from the beginning into how the implementation would work, maybe the story would be different. The story we're telling you today would be a bit different. So we know the PROMs were developed for research. They're long, they're English only, they're mainly digital in most cases. So if this could be hybrid, simplified, translated, made for the routine care instead, the PROMs could look quite differently. We also need to think the amount of time the clinicians have with patients is limited. So we don't want to spend that by talking through a huge questionnaire. Instead, we want to make things work for the service rather than trying to shoehorn a long form questionnaire into the service that is running. If you enjoyed this presentation and want to have a look at the research, everything is being published. So this is the scoping review we mentioned at the beginning. This informed the whole evaluation. The released evaluation is also published in the Journal of Advanced Nursing and is available. And the SRY is also available in the Journal of Patient-Reported Outcomes. And before we finish, I just wanted to acknowledge Maxine. She was fantastic. She was a member of the health board, and she helped us with recruitment. Without her, this wouldn't be a successful research project. So thank you, everybody.
Okay, thanks very much, May. So a lot of learning here, and I just wanted to add that the champion that you mentioned in the heart failure service was a consultant nurse. And you just walked into that service and you knew immediately that it was well run. It was very efficient. She was inspirational. So the personalities are really important. And I can see in the chat that Tyler's put about the staff training as well. And one of the key things is around training and retraining, and implementing interventions can be, existing practice can be very sticky, can't it? And it's quite easy to default back to existing practice. And I think, the key message here is that research instruments don't translate easily to routine clinical practice. It's unreasonable to expect patients to constantly fill out the same battery of patient-reported outcome measures time and time and time again, and that the response rates reduce over time. And so therefore, fewer and fewer patients complete them. And, with 3 long-term conditions, it can become really, really boring. So while you've been speaking, I've been answering lots of questions in the chat. I can see that Debbie Schaefer's online, and it's absolutely lovely to see Debbie. Debbie is one of our patient and public involvement representatives for the New Women's Health Research Centre. Debbie, I don't know whether you wanted to just put your microphone on and ask your question.
But can you hear me?
Yes, we can hear you fine.
Hang on, I'll put my camera on as well.
It's lovely to see you.
Hi, Jane. Oh no, you can't see me still. Thank you so much for what a fascinating presentation. And just my last comment in the chat was just how much it resonates and echoes the conversations that we're having at the moment with NHS Wales around developing a PREM and potentially a PROM for use in the new women's health hubs across Wales. All the comments about using different formats, about co-designing, hugely important. So the question that I asked right at the start, Jane, and in fact it did get answered by colleagues towards the end of the presentation, was around disaggregation of data, particularly when it comes to the data that's being routinely collected in secondary care. And we know that currently it's not always disaggregated by protected characteristics and other sort of circumstances and needs. And I suppose my question was, and as I say, it was answered, was that did you find that to be problematic in terms of establishing what constitutes good outcomes and good value for different groups of people? As I say, I know you've answered that already, but yes, thank you very much.
That's a great question, Debbie, and there is a bit more elaboration we can put in there, is that the patient reporting outcome measures were often put together, or 2 or 3 for each condition. They were all selected by the value-based healthcare teams, and there's sort of an agreement across the value-based healthcare teams in England, Wales, Northern Ireland and Scotland as to, you know, what would be a core outcome set for each condition. Having said that, the outcome measures for some of the conditions didn't measure what the patients considered as priorities. And so therefore they didn't capture what the patients wanted to achieve, what were important to them. And so therefore, you know, you have to actually sort of think, well, what value have they? Because this should be around thinking about what the patients want out of their care. And, you know, in clinical practice, often it's quite symptom based, isn't it? What are your symptoms? Are they controlled? Whereas patients wanted something often a little bit different than that. They much wanted to consider their quality of life, you know, what their long-term prognosis might be, etc., etc. And it did vary on the conditions. I think the other thing that's really important is that where there is no return on investment and the money has been given to services, but there's no benefit to patients, should the health boards continue with it? Should they take that money back and reinvest somewhere else and disinvest in using of PROMs in routine practice? That's a real question, isn't it? We should be disinvesting in interventions that aren't effective and that don't reach everybody. And I think it is you know, especially in things like Parkinson's disease, expecting increasingly elderly, frail people to have a mobile phone and to, you know, fill out extensive questionnaires online or on their phone is problematic. So there are some good outcomes for PROMs, but there are some negative outcomes from PROMs. And I just wanted to finish off in the last couple of seconds today to say that the team produced the first realist evaluation and the first social return on investment in this field. And it shows very different findings. So the PROMs teams and the value-based healthcare teams are very evangelical that all of this is working. So we challenged their sort of assumptions that everything was hunky-dory and fine, and that, you know, value-based healthcare was a great thing. And we've said that it works. We've challenged those assumptions and said it works in some areas, such as heart failure, but not in others. So we've challenged the orthodoxy. We've rocked the boat a bit, which is what good research and evaluation could do. And then just finally, just a message back to Debbie. I wish we'd have had the opportunity to look more at women and women's needs as disaggregated from men's needs, because I think that's very important. We, you know, in future, if we had more time and more money, we would have liked to have done some more subgroup analyses within the conditions to see if women fare differently than men, older people versus younger people, whether people from minority ethnic communities fare differently when they try and use PROMs and integrate with their care. So we do need we could have explored more about equity if we had bigger numbers, and this is the largest you know, realist evaluation that's been done and the only one with PROMs thus far, so it's quite unique. So I don't know whether there are any other questions that you put in. You've surprised me because you put the questions in the chat and not in the Q&A, so I'm sort of running backwards and forwards, but if there aren't any more questions, I'll hand back to Lorelei.
Thanks very much, Jane. That was just such, you know, such an inspiring presentation, not just, and to Ellie and May as well. So not just because of the interesting findings, but because it's such a robust study design. So thank you for that. And thank you everyone who came along today. I hope you'll join us again in the future for another Academy for Health Equity seminar. The next one is 11th of March, and that will be, I think, Kat Ford talking about adverse childhood experiences and health outcomes. So I hope to see you there. Thanks again, everyone.
Lovely to see everybody. Thanks so much. Enjoy
Well,
your lunch now.
Thank you.
Bye-bye. Bye.
Bye. Thanks. Bye.